Okay, I believe we are live. Good afternoon, everyone. I am Jennifer Petty, Mrs. Atlanta 2022, and welcome to Maternal Health Outcomes. Where do we go from here? I am so excited to be joined by esteemed maternal health champion, Rose Horton. She is Executive Director for Women and Infant Services at Emory Decatur Hospital, past president of the Association of Women's Health, Obstetric, and Neonatal Nurses. And she was recently appointed to the White House Black Maternal Health Stakeholder Group, which is a 36-member partnership between the U.S. Department of Health and Human Services and March of Dimes. I am sure many of you are familiar with the viral hashtag, not on my watch, which she started due to growing frustration with the maternal mortality statistics. Rose, welcome. I'm elated that you have joined me to have this very important conversation. As a public health strategist, mom, and near-miss survivor, this is just a topic that is, of course, near and dear to my heart, and I know it is to you as well. So I'd just love for you to first share more about yourself and tell us what motivates you to do this work.
Yes, thank you so much, Jennifer, for inviting me to this conversation. Yeah, it is totally my passion. I call it now my life's work because I can't imagine not being an advocate for the birthing community, especially the BIPOC birthing community. So what drives my passion ever since I was in college and in my first clinical rotation in OB, I knew that I wanted to work with the birthing community. I was mesmerized and transfixed by my first birth. My eyes filled up with tears, and I was like, this is so beautiful. I want to have a part of this. So it was really clear to me early that I wanted to work with the birthing community. And I feel very privileged and very blessed that I've been able to do that throughout my career. And around 2017 is when I really started feeling more concerned about maternal mortality because our numbers continue to increase in the United States. Even though we spend the most money per capita on healthcare, and seeing article after article in the lay media, not just in our healthcare and peer-reviewed journals, but in NPR or USA Today or New York Times, and I just felt so frustrated. So angry. I think I say frustrated as a nice word, but I was really angry about it. And the hashtag not on my watch came to mind. I'm like, you know what? This is not going to happen on my watch. And I shared my concern with my leadership team at the hospital. I said, y'all, I created a hashtag and I really wanted to go viral. I said, even if viral just means within the walls of our hospital, let's make this go viral. And I was really surprised how it resonated with folks within our hospital and our healthcare system. And when I created the hashtag, it was also like a call to action. As a nurse, and a nurse who is fortunate enough to have a national platform, I wanted other nurses to join arms with me to say not on my watch, because I believe in the power of nurses and the power of nursing. So I did pitch this in 2018 during a national convention, and it did resonate with lots of the nurses who attended the convention. And thankfully, others have been using the hashtag, on Twitter. It's mostly on Twitter, but also on other social media platforms. And what it means, I'll tell you, what it means is, I'll make believe, Jennifer, that you're my patient. So when I engage with you at the beginning of my shift, what I'll say to you is, Jennifer, in the time that I'm caring for you, I commit to, first of all, treating you with dignity and respect. I commit to listening to you and believing you, because we know that as Black women, nobody listens, nobody believes us. So I commit to listening and believing you. I commit to taking care of you in an evidence-based manner. And what that means is that we're not going to form any opinions. We're not going to be arbitrary. We're going to follow the art and the science that is healthcare. I commit to advocating for you. And finally, I see you. I see you. I'm your person. And that's what I wanted all nurses to say and to mean and to follow up with their behavior with that. And whenever I say it to folks, they're like, oh my gosh, that's so great. It's really a great way to take away my stress and my anxiety to know that somebody's got me. So that's a little bit about me and the passion and about the hashtag and where we are today.
No, that's amazing. And I love that you turned this into an opportunity to create this enormous call to action. And I know it's more than timely. We know that statistics are showing that the number of women dying giving birth in this country continues to rise. And just, I guess, talk to me a little bit about how did we get here?
That's a really good question. We've been rising. We've been on an upward trajectory for over 20 years. So unfortunately, this is not new. I remember looking at some stats and I think in the late 90s, and it showed that we were like right around number 45 or 46, the United States, as it compares to other industrialized countries. So we've to use the vernacular, we've sucked for a while, and it's embarrassing. Whenever I use that slide and speaking to folks, I'm like, I'm embarrassed by this and I want us to change this. So we've been on this upward trajectory for a while. I think there are a lot of things that contribute to it. It's really multifactorial. It has many layers, so I'm not going to purport to say doing this will fix it. I think there's many layers. I think many people have skin in the game. I think providers, physicians, I think nurses, clinicians, I think the hospital system has skin in the game. I think legislators have skin in the game in the bills that we move forward or we don't move forward. I think our processes, there are so many things that really contribute to this. So what I say is, what is my locus of control? My locus of control is for the units that I have oversight of. We're going to make sure that we don't contribute to it. I'll give you one example of how us as healthcare employees play a role into it. I think probably over the past 30 years that we've really medicalized pregnancy, labor, and birth versus seeing it as a normal physiologic event. So when we medicalize something, it almost becomes like a disease state that needs intervention. So you need to be induced. You need to have your membrane ruptured. You need to be scheduled for a cesarean section versus like the midwifery model of care, which says that pregnancy, labor, and birth are normal physiologic events, and our bodies really recognize when it's time for us to naturally go into labor. I'm not saying that everybody goes into labor naturally because I had to be induced twice at 42 weeks. So I know that can happen. But at least we were at 42 weeks because I was like, let's wait till the body does it, right? So I know that that can happen. But let's make sure that we intervene when it's necessary to do so. So I think that's just one part of the problem that has escalated us to have more interventions. The more interventions that we have, the longer a woman is in the hospital, the longer you're in the hospital, the more likelihood that you'll get exposed to things that could, make you even more, make you exposed to something that could really have an impact on your outcome, so maybe to getting an infection or just exposed to something. So all of that has compounding effects. And if I were king, not queen, I want all the power. If I were king, that is probably one of the big focuses that I would do is let's start normalizing that pregnancy, labor, and birth are normal physiologic events. And let's have more stringent processes about when and how we intervene for women.
Sure. No, that's great. There's so much that I want to unpack, but I love that you mentioned, I guess, the length of time in the hospital. I last year, around that time that I had my daughter, I was in the hospital a little shy of a month. And I'd heard this phrase before that nurses are the heart of healthcare, but I think that really resonated once I was there that long because, who did I see more often, right? I saw my nurses. And I'm curious, based on the information that you just shared, what unique position do you think nurses are in to help kind of move the needle when maternal health outcomes are concerned?
Yeah, so that's why I partnered with my nurses because I think we have a lot of influence. I remember as a staff nurse, my first job as a nurse was a staff nurse in labor and delivery. So I would have been that nurse taking care of you when you came into the hospital. So you're right, we're the largest healthcare contingent. There's 4.2 million of us. So we outnumber everyone in healthcare. And we have influence. We have influence because we spend the most time with you. So we're able to see any nuance in how you are, not just how you're being cared for, but the outcomes. So we'll see because we've been taking care of you. Oh, I think her blood pressure is going up just a little bit. I think her respiration, this is breathing a little bit faster. I'm concerned because her outcome, she was urinating this much an hour and now she's urinating less. So all of those nuanced things we see because we spend the most time with you. And also we have great relationships with the providers. They trust us because they have like this whole other life, which is their office that they have to manage. So when the patients in the hospital, they really trust us to partner with them, to be their eyes and ears and to collaborate with them and to let them know when we're concerned about something or let them know things are going great, you're fine, go ahead and do what you need to do in your office. We're managing it here. So that's another influence that we have because we have really great relationships with the providers. And as nurses, we have something in nursing called a code of ethics. ANA has a code of ethics, and one of the tenets of the code of ethics is that we advocate for our patients. So what that means is it's that old adage, when you see something, say something. So advocating means I call the provider and say, I'm really concerned. I think you need to come in, or I think we need to intervene. Maybe we need to consult, another specialist. So I advocate for the patient. Or if the patient says to me, Rose, I really don't think I don't think anybody's listening to me. I just feel like I'm talking into the wind. That's my job to advocate for you. You're not talking to the wind, Jennifer. Tell me, what are your major concerns? And I will amplify your voice for you. I will be that. So I think that's other things that the nurses can do. And I kind of wove all of that into Not on My Watch, that we're following the science, we're listening, we believe, we advocate, um, we see, because it's so important to be seen. I don't think there's a greater compliment than somebody just saying, I see you. It's like, okay, okay, I'm seen. So yeah, that's what I was thinking of.
That's amazing. I applaud your approach that you just articulated. I think that that is amazing. And when I think back to just my experience, as well as just experiences that I've heard from friends, associates, friends of friends, I know that it would have meant the world, I think, to have been approached in that manner. And I guess, so that being said, how do you think, or do you think there's a role for nursing schools to play in, I guess, in the training process, right? As to, these are the types of conversations, these are the values that should be portrayed. Do you think that there's a role for nursing schools in this?
Yes, I'm sorry. I'm so excited that I'm interrupting you. I don't mean to. Yes, that is such a really, really great question. And yes, I do think that there's a role. So let me tell you a little bit more what my thoughts are. I do think that there's an opportunity to really teach to what is current practice versus what's historically been in our textbook. So teach to what's current practice. I think I do believe that the nursing schools do this, but I think something else that we can continue to do is really empower the nurse to recognize that she has a voice and that she really impacts outcomes. So I think that's really important for nursing schools to do. And the other equally important, but definitely more timely, is I think we need to have more robust diversity, equity, and inclusion courses in nursing today, because we know that implicit bias and racism plays a role in outcomes. So we have to really, directly have those conversations, because I know that's not something that I learned in nursing school, because it wasn't such a big thing. We didn't have the correlation now with outcomes. But now that we do, I feel like we can spend a whole semester. Actually, I feel like the whole program needs to be woven with an equity lens so that that comes up in every class we take in nursing, not just the anatomy and physiology, but all the courses that we take. How do we weave in equity into that? So absolutely, that's what I think nursing schools can do. Nursing schools can promote anti-racist behaviors and values.
That's interesting. I on March 17th, time is flying. So on March 17th, I facilitated a webinar with some amazing moms who share their birth stories. And one of the moms who Black mom experienced gaslighting, where her providers during her delivery process told her that or they did not take her pain seriously. Um, and so I think she is still, I think, dealing with the aftermath of that. Another mom on the same webinar explained that she was denied the ability to, I guess, change her position. So she was, I guess, it was required that she lie down in the bed, despite the fact that she had asked to, I guess, assume a different position. And so I guess my question: how can birthing people support people? How can they best navigate if they find themselves in this unfortunate situation in a hospital setting?
I think, and that's another really great question. So my preamble to that, I just want to say, I feel, this is Rose Horton speaking, I feel that it's unfortunate that I have to ask birthing people to advocate for themselves.
Mm.
It's like asking the victim to advocate for themselves. Where else do we do that? So I just want to say that let me just start with that. It's unfortunate. Having said that, I know that it is important for people to do exactly that. And there's a course that I teach. I call it Colonialism and the Black Birthing Experience. Um, and we go there in that course. It's created by a Black women for Black women, just to talk about the whole birthing process. But what I say in that course is that your voice matters. It's really great, especially now. We'll knock on wood for the time being, now that some of the COVID restrictions are lifting, and most hospitals are allowing at least two people to accompany, two care partners to accompany the birthing person to labor. Get your village to also amplify your voice. It's important for us to be on the same page and articulate what's important. It's important that I move. It's important to me that I don't get an IV. It's really important to me that I have a vaginal delivery. It's important to me that we have some sparkly lights in the room. Whatever it is that's important to you and that you've spoken to your provider about already, make sure that you guys are on the same page. And so that you can have your village advocating for you as well. Because if you're in labor, and it's been a while, but I do remember those labor pains. You're not gonna, that's a lot. You need to focus on your body and focus on what's going on. So get other people to amplify your voice. If any birth moms are listening or future birth moms, what I want to say is that in every hospital across the United States, there is a chain of command. There is always in every unit a nurse manager. So if you feel like your nurse is not listening, if you feel like your provider is not listening and you've asked your nurse and your nurse is not helping you, there's always a nurse manager. There's always a director in the chain of command. There's always a chief nurse officer. And every hospital has a CEO. If you need to go as high as the CEO, it is within your right to do that if you're not being heard. Because traumatic birth is a huge deal. It impacts um, mom's ability to really establish that relationship, that bonding relationship with their baby. Sometimes it impacts breastfeeding. If there's an intention to breastfeeding, it impacts healing. It could have an impact on depression. It's a big thing. So whatever we can do to mitigate trauma, let's go ahead and do that. So I also talk about certain words that we as healthcare providers we listen to. We call them cuss words, with the C being, I'm concerned. So if you were to say to me, Rose, I'm concerned that nobody's listening to me. So C is concerned, I'm uncomfortable.
Mhm.
S is safety, CUS. I feel like this is a safety concern. I've been complaining about this pain for 2 hours. I don't feel safe. I feel uncomfortable in this organization. I am concerned about the level of care. So the cuss words are words that, we've been socialized with and that we respond to. So those are some ways to do that. Again, it's disappointing that we have to, ask you to do the advocacy and ask your village, but those are things that you can do. So bring your village, make sure you guys are on the same page, um, use those words, escalate the chain of command. And always, it's easier to be heard when you're speaking with kindness. I know sometimes as a patient, you don't always receive kindness. I hope we're seeing less and less of that, but it's always easier when you receive kindness. One last thing that I will say, I just had a speaking engagement in Salt Lake City, one of my first in person. So I was in Salt Lake City last week. And one of the nurses in Salt Lake City is extremely homogenous. There's not a lot of people who look like me there. And one of the nurses asked me a question that I absolutely loved. And she said, Rose, sometimes when I have a Black patient that I'm caring for, I feel uncomfortable. I'm worried about doing the wrong thing. And I love that she was courageous enough to ask the question. I'm like, that's a great question. Let me tell you how to do that. So I talked to her about not on my watch. If she starts that way, it really de-escalates everything because, we just want to be seen. We want to be heard. We want to know that somebody's advocating for us. So I told her about doing that. And I told her another thing that I learned years ago. I said, listen, there's a stereotypical comment that goes around that Black women are angry. I said, I want you to know, based on really good data, that anger is never the first emotion. I said, so if you have a patient that just seems really angry, that's bristling, anger is never the first emotion. There's probably fear, there's probably hurt, disappointment. It's never anger. Anger is a defense mechanism to protect us. So I said, I encourage you, start with not on my watch. Give that person autonomy and agency. That should be fine. But then tell them, I am here to support you so that that fear can dissipate, which you probably see as anger. So that's some of the taglines that I'm trying to use just to give people permission, right? That's what I'm trying to do. You're having a hard time with Black women. I know Black women. I am Black woman. Let me tell you what would work with me. So.
That's amazing. That advice is, I'm sure has empowered everyone listening, everyone who will listen to this even in the future. So thank you so much for sharing that. It's advice that I would have loved to have heard last year myself. So thank you. You mentioned a lot of the adverse effects that traumatic births can have on moms, on babies, even on support people. And I think one thing that you mentioned was the potential impact on breastfeeding. And so I am someone who my breastfeeding was adversely impacted by my traumatic birth. And so I guess
Sorry.
Yeah, and it's not something that I guess I did not even realize the correlation was as strong as it was prior to going into, giving birth. And so I guess I'm curious, in what ways can nurses help facilitate something like that? What opportunities exist for a nurse to help with that, especially in a scenario where there was a traumatic birth?
To help with your breastfeeding?
Mm-hmm.
Um, so a lot of things. In my hospital, every nurse on the mother baby unit is an expert in breastfeeding. And then we have a higher level of expertise in our lactation consultants. So we have lactation consultants also, but we understand that with our birth volume, they can't see every patient. So we usually have a criteria for who they can see. So the staff nurse, the clinical nurse will start first to help you with latch, help you hand express milk, help you with finding positions. You know, when you first have that baby, you don't know how to hold them to get them there. You know, they can help you with that. The nurse also she can be your champion because sometimes we just need to hear, you're doing a really great job. You really are. Or, you know, you're doing a lot right now. How about if we take a break and we try again in an hour? So the nurse plays that role as well. And also, we're a baby friendly hospital. It's a designation that you can apply for, very stringent because baby friendly means that it's a friendly organization for breastfeeding, so that we need to meet specific guidelines because we think that breast milk, chest feeding, human milk is best for babies. And to that end, what do we do to ensure that our patients are successful with that? We do have a breastfeeding support group also, because, you know, for the most part, after you have your baby, you're in the hospital for 48 hours and then you're gone. So we know that it's a journey because when your milk comes in, it's like, yikes, what happened to my body? What are these things? You know, so you still need support on how to pump, how to express the milk, you know, all of that. So we've put a couple of things in place to help ensure that our patients are successful with breastfeeding. But definitely the nurse plays a role in that, in recognizing that this is something that's really important to you and what can they do to ensure that you're successful, because your success is what's important to us.
Sure, sure. I appreciate that. Guess when we think about hospital births, so births that take place in a
Mhm.
hospital setting, I know that, you know, I guess typical of maybe a new mom. When I first learned I was pregnant, I said I was going to do all this research and, you know, on local hospitals to, you know, I guess inform my decision as to where I wanted to give birth. And I think I was surprised about how I was surprised that it was really challenging for me to get my hands on that information for some of the hospitals
Mhm.
in the area. So things like maternal health outcomes data. There were a few hospitals that made it really hard. I felt to kind of obtain that information. And I'm curious, do you think that more hospitals should be transparent about that type of data, and should it be seen as a red flag if they aren't?
Yeah, I was trying to Google while I talked to you.
Mhm, mhm.
But there's a hospital compare,
Okay.
hospitalcompare.gov. I'm just trying to make sure. Hospital Compare is a CMS page, and we have to share data. It's a requirement
Mhm.
for us to get reimbursement from CMS. So there's lots of places that we have to report data. So there's places to go to find it. So you should be able to go on the cms.gov page, and my phone is acting silly right now, and put in the state and get some information. Um, says, we're sorry, but your search has resulted in an error. So anywho, but I see the hospital compare .cms. That's a great place to go and to start looking. And there's nothing wrong with calling. Again, this is publicly shared information, like our C-section rates, breastfeeding rates, that's publicly shared information. So there's nothing wrong with calling the hospital and say, hey, I can't seem to find your data. Is there somebody who can share this with me? Because we'll do that. And sometimes I think it's Parent Magazine. There's a magazine, especially in the state of uh, Georgia, that shares some data also on a yearly basis, like, you know, all of that stuff, like how many beds do you have? How many births do you have? What's your breastfeeding rate? What's your C-section rate? So there's that. Another really exciting thing that maybe you haven't heard, but US News and World Report, you know how they have like the best hospital for orthopedics, the best hospital for cardiology. So in November, US News and World Report just jumped into the best hospital for maternity, which we've never done before. Yes. And that makes me super, super happy. So that's another place to go to see where you rank. And they're looking at all the same things. Again, C-section rate, breastfeeding rate, induction rate, and some other rates. So if you want to be the best, you're going to go ahead and report the data. And one really great thing that I love about that, I was so fortunate that US News and World Report asked me to be part of their team when they were coming up with some metrics. But one thing that I love, because I kept saying, listen, data is great, aggregate data is really great. However, we need some stratified data because that points another picture. When you lump everything together, it looks one way. But when you say, well, I wonder what my C-section rate is for Black women. I wonder what my breastfeeding rate is for Black women. So I talked that up so much that the next iteration, which will be in 2023, they're going to start asking hospitals, are you stratifying your data? And are you willing to share your data based on they're going to start with race, but we know there's many ways to stratify our data. So exciting things coming down the pike. So there's ways to find out this data.
Huh. Interesting. We talked about nursing schools, which I think was important. What about professional associations? So I see, I think if I remember correctly, I read that the Association of Women's Health, Obstetric and Neonatal Nurses, that they're releasing guidance for respectful and safe
maternity care. Yes.
How do you think this will help facilitate improvement? And what are some additional things that you think could be done down the line?
Yeah, I think that's huge. I think it's really important that we, as nursing associations, A1 has 25,000 members, so that's great. And there's about 250,000 nurses who work in our specialty. So they may not be members, only about 10% are members, but they definitely follow the A1 guidelines. So I think nursing associations are definitely an appropriate platform to start having conversations around racism and how it impacts care and the importance of respect. Now, ANA, the American Nurses Association, which is like, I remember I heard the president of ANA probably 7-8 years ago. She said that because she was having a conversation with me. I'm like, oh, hi, I'm the president-elect of A1. She's like, oh, I'm the president of ANA. She's like, are you a member of ANA? I said, I'm not a member of ANA. I'm a member of my specialty organization. She's like, well, I want you to think of ANA as your mama. ANA is your mama. Every nurse needs to be a member of ANA. And then you can be a nurse of your specialty organization. So since then, I've been a member of ANA. So ANA is like the largest nursing association. And they, in 2021, came out with a really strong statement about racism within nursing, within the profession of nursing. So going back to nursing schools and the importance of associations. So that made me super proud again. Okay, ANA, you're saying that we have a problem. Thank you for acknowledging that, so that the nursing schools are going to be influenced by what ANA says. And ANA is going to make recommendations that other hospitals are going to implement that will influence how patients are taken care of. So again, as I mentioned, so many people have skin in the game, and I failed to mention associations. Thank you for calling that out. Associations definitely have skin in the game and can influence this. But the Respectful Maternity Care Toolkit was launched in January, the last week of January, and it was fantastic. And I think it's going to be great. The toolkit is absolutely free for A1 members. And there's a nominal fee for non-members, but it really gives you like 10, I won't say easy, but maybe 10 rational steps to do to transition your organization to a respectful maternity care focused organization. And with every step, we have like a video, 3 minutes or less video, just talking about why this step is important. We have resources and links because we want to make it easy for folks to adopt best practice. And best practice is us following our code of ethics and treating everyone with dignity and respect. That's what the code of ethics says. We treat everyone with compassion, we advocate and we promote everyone, and we make sure that we treat them in a respectful manner. So yeah, I'm really excited about that, and I think it's going to be a conversation changer, definitely, for us. And it also, what I love is that it is getting out to the lay public. What I would love to see in the next, I don't know, 7, 8, 10 months is that consumers are saying, "Oh, I heard about that respectful maternity care toolkit. Is your hospital using that toolkit? Tell me about your commitment to treating everyone with dignity and respect. What have you put in place to ensure that that happens? How are you measuring your success?" Let's be true consumers and ask these questions so that we can continue to move the needle.
Sure, sure. That's great. That's awesome. I'm glad that associations are doing this work. Um, are there additional resources that you're aware of that may help standardize care for birthing persons?
Yeah, so the resources are for us, right? They're created for the hospitals and for nurses. There's CMQCC, the California Maternal Quality Care Collaborative, CMQCC. They did an amazing job creating some toolkits and some bundles to help standardize care. The state of California has done a really great job at decreasing, while the rest of the state has an increasing rate of morbidity and mortality. California has consistently had a decreasing rate of morbidity and mortality. So they're doing great, great work there in the state of California. So AIM also, the Alliance for Innovation in Maternity, AIMS, they have really, really great bundles as well to help standardize care and help us elevate the bar and how we care for folks. ACOG, the American College of Obstetrics and Gynecologists, ACOG, they have some toolkits. We have some toolkits. So there's lots of resources out there to really help us standardize. It's just about making sure that they're implemented and then creating an accountability loop, which means if you have this in place, if I've invested like this much money in education so that everybody knows about the toolkit, we have the documents, we have the forms, we've done the education, we've even done some drills. What happens if I don't follow it? I think that's an opportunity for healthcare organizations also to create that accountability.
That's great. I was not aware that that existed, all those two kids. So I applaud that.
And those, especially in CMQCC, they're available to the public. You just go on their site, you can see everything. Everything is downloadable, so you can, which I love. Let's be really transparent, make it available.
So I'd like to shift.
Okay.
Where is a success story that you have heard and or come across yourself directly in your work that has contributed to not only motivating you to continue this work, but also that could potentially inform providers who may be tuned in to this live?
Success story. All right, I'll share one. I would say right around 2018, so shortly after Not on My Watch, we started very intentionally with what we call our journey towards equity. So we're very intentional. We did some journal clubs to read some articles about it and had journal club conversations. We looked at video vignettes. We looked at our processes to see how do we change this to really use the lens of equity. So we did a lot of things so that we can, just to give you a little background in case you don't know, I'm not sure where you are in Georgia, but my organization, about 60 in my service line, the patients that we care for, about 68% of our patients identify as Black, non-Hispanic, so um, we have a very diverse patient population. About 68 are Black, 13, 14% are white. We have about 8 to 9% Latinx, and then I think 4% Asian, and the balance is other. So we have a very diverse workforce, and we wanted to make sure that um, we weren't contributing to poor outcomes, and that we were ensuring that we're providing the best care, and we were addressing our opportunities to again not be part of the problem. So in 2019, we started a disparity dashboard, something that Ames has available. It's really truly focusing on looking at our data with a stratified lens. So when we started looking at our data, separating it, peeling the layers back and separating it by race, um, we we saw a lot. We saw a lot of opportunities, and then so it was like after you see the data, what do you do? It's like, okay, well, what are we going to do? So we did put a couple of things in place that I won't go into detail now, but what I love is that our data point was at one place. We looked at it and we mourned it, and we said we can do better than this. And we put some initiatives in place, and our data point increased significantly, which told us two things. Number one is that we're nimble enough that we have the ability to change. Number two, interventions work. So that was a huge success for us when we saw the data point change consistently. Since then, the data point has done this, it's gone up and down. And we just had a conversation a few weeks ago, one of those difficult conversations that you have as a leader. It's like, y'all, this is all us. This variability is all us. We need to stop this to ensure that we're being consistent, because if we're consistent, the data point will remain consistent. Like, so we need to divvy up to come up with some tactics that will help us be consistent so that our outcomes will be consistent. And it's just been a couple of weeks, and we're checking this weekly, right? What gets measured gets done. It's an old adage, and it's very true. So we're checking this weekly, and I'm telling you, within a week of having a very difficult conversation and having a brainstorming, strategizing meeting, we have seen success. It's like, okay, our objective is to keep it above 80%. We don't want this 80 one week and 65 next week. So that's been a success for us. And again, I recognize that it's a journey that's going to take all of us being intentional and focused on the outcome. So that has been great. Challenging and sometimes painful, but at the end of the day, we're making an impact, and that makes me happy.
That's amazing. Thank you for being intentional. I just want to pause. I took a quick look at the comments in the live feed, and I just want to let you know, in case you're not able to see it, there are several, I guess, participants who are raving about the tips and that you provided. So thank you. It makes me happy, and that for me is a win, that the information that you shared is able to empower those who are tuned in. So thank you so much for
that makes me happy as well. Thank you. I said, I can't see anything. Is anybody putting hearts in here? What's happening? I'm like, I hope they're loving it, and I hope it's helpful. Not from a vanity perspective,
No,
I'm not that girl, but I just want it to be helpful.
It is. If you saw me looking down, that's what I was doing. I was looking down so I can keep tab on the comments that are being made. So
Good.
And the loop. No, yeah. Definitely a lot of feedback. Folks really appreciate this. So thank you.
Of course.
Any final words that you would like to leave, either with
Yes.
providers and or birthing people, support people?
I do have a final word. Thank you for asking. I didn't think I had one until you asked. I'm like, I do have a final word. Um, what I want to say is I have a good friend, Joy Baker. She's a physician, Dr. Joy. She has a YouTube channel. She's amazing. But we've been talking lately. So here's the deal. We've done a great job talking about maternal morbidity and mortality to the point now that Black women are terrified. If I've seen one tweet or one IG post, I've seen several. I just found out that I'm pregnant and I'm terrified. And that absolutely breaks my heart. So we need to, as the BIPOC community, we need to change the narrative. I don't want anyone going into 9 months of pregnancy with that level of cortisol and stress hormones floating in your body. We have to find a way to change the narrative to say, you know what? Because the words we use is a tenet from the concept of appreciative inquiry that I've used for years and years and years. My daughters can recite it verbatim. The words we use creates our reality. The words we use creates our reality. So Joy was telling me that she was talking to one of her patients and saying, hey, tell me what you want your birth experience to look like. And she said, I just don't want to die. And Joy was like, oh, wow. I wasn't ready. I was just wondering, do you want to get up and ambulate in the room? Do you want some lights for, aromatherapy?
Mm-hmm.
But she doesn't want to die. And both of us took a moment, to hold space for that and say, oh, we need to change the narrative. We need to talk about birth as joyful, birth as sacred, birth as a blessing and a privilege. So what I would like to say is, yes, there's the ugly maternal morbidity and mortality that exists, but don't let this be what overshadows the experience. Our bodies are beautifully created, wonderfully created, just for pregnancy, labor, and birth. It knows what to do. Do your part of taking care of your body, taking care of that vessel. Positive energy, positive visuals, positive self-talk. Tell yourself you're gorgeous, you're capable, you can do it. And let's change the narrative for the Black birthing community.
I'm so glad that you chose to highlight that in your final words, because when I think about my own social circle, that is a trending conversation. And I have good friends who I think maybe tuned in who, have decided to maybe delay due to that fear. So thank you so much. And hopefully that will provide additional comfort to those who may be feeling that way.
I hope so.
That's yeah. But this has been an incredible conversation. I've just enjoyed speaking with you. I love your positivity. However, just how candid you are in ways that we can and need to improve. So just thank you, I guess, not only for myself, but on behalf of all moms, birthing people, support providers who may be tuned in. Thank you for all you've done. We'll continue to do as Women's History Month comes to an end. I definitely have to acknowledge you and just the great impact of your work. I think your work is the difference between life and death, literally. And so I just love everything about it. So indeed, hashtag not on my watch. Thank you.
Thank you. Thanks so much, Jennifer. Thanks, everyone.
Thank you, everyone. Thank you for joining today's conversation. I'll just kind of remind, please tune in on April 14th. We'll be having a conversation with author and policy analyst Anusha Hussain, who will discuss her book, The Pain Gap. On April 11th, we'll launch a PSA for a Black Maternal Health Week. And on April 19th, I will be joined by attorney and U.S. bankruptcy trustee Jason Petty, who will discuss navigating maternal care costs. Thank you, everyone. I appreciate you spending your lunch hour with us. And together, let's continue to improve maternal health outcomes. Thank you.